Welcome to Diagnosing Health Care, a podcast featuring thought-provoking conversations about the latest legal, policy, and regulatory issues in healthcare. While these issues may seem like hurdles, we'll also look at the business opportunities and solutions that exist. Diagnosing Healthcare is brought to you by the healthcare lawyers at Epstein Becker Green, a leading law firm serving clients in the healthcare industry nationwide.
Today on Diagnosing Healthcare, we will discuss reimbursement and compliance considerations for direct access laboratory testing stakeholders. Hello and welcome. I'm your host, Megan Robertson. I'm an attorney in Epstein Becker Green's Healthcare and Life Sciences practice based out of our Washington, D.C. office. When you think about the life cycle of any healthcare product, a key component that must be considered early on is how much the product will cost and who will pay for it. Lab tests are no different in this respect. However, direct access tests pose unique challenges when it comes to reimbursement and related compliance requirements. Today, on our second episode of the Direct Access Laboratory Testing series, we're digging into the topic of coverage and reimbursement for direct access tests, as well as the related compliance factors that labs, product developers, and investors in the diagnostic testing industry should be aware of. If you like what you hear today, please subscribe to the show. Diagnosing Healthcare is available wherever you get your podcasts. Joining our discussion today is EBG Advisor Dr. Joel Brill. Joel is an internist and gastroenterologist and is the Chief Medical Officer of Predictive Health. He is an executive clinician with over 30 years of experience. He regularly advises organizations and businesses on coding and coverage considerations under both government and commercial payers, and has also been a medical director for several health plans. He is skilled in strategy, development, and implementation of innovative health programs, products, and payment systems, with extensive experience in clinical practice, research, coverage, reimbursement, quality improvement, bundled on episode payments, and accountable care. Joel, we are excited to have you with us.
Thank you.
Also joining us for episode 2 of this series is Bob Hearn. Over the last 20 years, Bob has dedicated a significant part of his practice to working with clinical laboratories on a wide array of legal issues impacting lab operations. He routinely assists with structuring business relationships between laboratories and hospitals or physician practices that comply with federal and state anti-kickback, self-referral, anti-markup, and direct billing laws and policies. Bob also has experience with state and federal surprise billing statutes and the application of consumer protection laws, such as the Fair Debt Collection Practices Act and its state counterparts, to patient billing by healthcare providers. Bob, nice to have you back for our second episode of this special series on direct access testing.
Thanks, Megan. Good to be here for episode 2.
So, as I mentioned earlier, coverage and reimbursement are crucial issues to consider upfront when developing a direct access testing model. Why is that? Joel, we can start with you.
Sure. And first, again, Megan, thanks so much for the opportunity to participate in this podcast. This is a very interesting and obviously evolving issue. We always like to say that there's the holy trinity: coding, coverage, and reimbursement. And it makes no difference whether we're talking about a drug, a digital therapeutic, a device, a diagnostic, or a procedure. Obtaining a code is not a guarantee of coverage or payment. And at the same time, you can get paid even without having a specific code to describe your service or your technology. Within the CPT, or Current Procedural Terminology Code Book, that's developed and issued by the American Medical Association, there are a series of codes for unlisted or not otherwise classified or specified services. So it's really important to assess, first off, what do you do? And if we're talking about a laboratory diagnostic, how will management change? How will outcomes improve when a physician or another healthcare professional uses your diagnostic to manage their patients? Answering that question goes a long way towards addressing, can this get covered and can this get paid?
Thanks, Joel. Bob, did you have any thoughts on this one?
Joel, I absolutely agree. Fitting novel products or medical services into the coding, coverage, and reimbursement machinery of our healthcare system is really, really complicated, but it's imperative to the survival of the provider or supplier and imperative to whether a service is going to help patients at scale. Having and executing a plan to obtain a positive coverage determination is a foundational issue for new medical services. And as we'll talk about today, modifying the delivery mechanism of existing non-controversial medical services like laboratory tests, even routine laboratory tests, poses a lot of the same reimbursement challenges as new services do. The question in my mind is, can you change the fundamental driver of a lab test from a physician to a patient and all of the associated ordering mechanisms without upsetting the reimbursement apple cart. That's the $100,000 or more question for direct-to-consumer lab testing operations.
And Bob, let me kind of come back and respond to some of the comments that you're making, some of the questions that you're addressing. There's a concept within the insurance industry and within Medicare as well, too. And that is that a healthcare professional is someone who assessed that patient and made a decision as to whether that test was medically necessary, how is it going to improve management, and then that order is going to, in effect, trigger the pathway from a payer standpoint. What you're raising is a really intriguing question, which is, can patients, people, users go directly self-order tests, and then can they get reimbursed for those? Or is it all cash paying out of pocket? Is that kind of the question and the postulate that we're trying to address here?
That is. And as we addressed in the first episode of the podcast, I think what a lot of folks that look at direct access testing from the outside see is a patient who goes online and orders a lab test just like they were ordering a roll of paper towels. And that's really, in most instances, not what's happening. There are some wellness-oriented tests that can be ordered without physician intervention. But what the consumer's not seeing, and what I think many people who are interested in getting in this business aren't seeing, is most of the time there is a physician in the ordering loop, right? The patient, it's him or herself, is not actually ordering the test. Behind the initiation of the request for a lab test, there's a doctor that's evaluating whether the test is appropriate for the patient, and then actually completing an order that allows the laboratory, from a regulatory perspective, usually governed by state law, to perform the test for the patient. So there is a lot more happening here. And as you postulate, the question here, and it's more than conceptual, it's more than theoretical, is whether when they initiate the process that leads to an order for a diagnostic test, does that somehow disrupt the medical necessity for the test? It's a big question, obviously, that people that are considering direct access testing operations have to consider.
For sure. And let's go back to this discussion about cash pay versus looking for third-party payer reimbursement. That's one of the first decision points for a lab that's considering offering a direct access testing product is whether the testing should be offered solely on a cash pay basis, or if they're going to seek reimbursement. So what are the drivers for a lab or a device manufacturer to consider when deciding between a cash pay model versus seeking third-party payment?
Megan, I think the first question that you're addressing there is, as you said, whose pocketbook is going to be paying for the test? Because if you're going for something that's cash pay, then it's irrelevant from an insurance standpoint, okay? The patient orders the test, or they go to the grocery store or the drugstore, they pick up the test, they do it, and it's done. And they're not really looking for insurance reimbursement. If you're looking for reimbursement, however, from your test from Medicare, Medicaid, commercial insurance, or the like, then your model changes, because then you have to have a physician who's ordering that test. Okay. And there has to be documentation that that physician is maintaining that they felt that that test was reasonable, was necessary, is going to monitor something that's going on in that patient's current medical condition or health. That leads to a whole slew of other questions. Is your test FDA cleared? Is your test a laboratory developed test? Are you running the only lab in the US where everybody has to come to you for this test? Are you offering a kit that other labs can purchase with your test? Those are questions you have to answer. If you've got a test and you're marketing direct to patients and you're trying or you're thinking about insurance coverage, do you have published peer-reviewed literature that talks about the analytic and clinical validity and the clinical utility of your test? Or is it, we think it's a wonderful test? Because in the absence of data, it's hard for insurance companies to agree to cover something. If you're marketing directly to patients, and I'm going to sidestep the legal questions of what needs to be done because I'm going to leave that to Bob in a moment. But if your business model is just, I've got a test, I'm marketing it to patients, I don't really care about insurance right now, and I'm going to have people self-pay, you should still be thinking about this question. Can I collect data? Am I collecting data that ultimately might lead to getting insurance reimbursement for my tests in the future?
That's really helpful. Thanks, Joel. I think the takeaway there for listeners is there's definitely some legwork needed in order to go down the reimbursement route versus cash pay. Although, like you said, even if you go the cash pay route, there's still an emphasis on the need to collect data about the tests and about the patients using those tests. Going down the third-party payer route, when a company or a lab decides to seek out third-party payers to cover their product, particularly if it's a government payer, what are some of the more specific questions that they should be thinking about? Some tests are more likely to be covered, for example. How would a lab go about thinking that? Bob, do you have thoughts there?
Many of the issues that Joel just touched on are really foundational to obtaining third-party payer coverage in any context, including for direct access lab testing. In my mind, the most basic ground-level question driving whether a lab test is a likely candidate for third-party reimbursement is whether the test is a screening test or a diagnostic test. Screening tests are ones that are generally performed on presumptively healthy patients, people with no signs or symptoms of a disease or a harmful condition. And screening tests are often just looking for an invisible biomarker that suggests an apparently healthy person could have a condition that requires further examination and possibly a therapy. Examples of these kind of tests are sort of commonly used PSA test that screens for prostate cancer in men, the relatively new fecal specimen-based colon cancer screening test that you see advertised or may have experienced yourself, and then HPV screening, which has become really prevalent for both men and women. And Joel, I'm interested. I mean, I want to make sure that I've characterized the sort of nature of a screening test correctly, and I'm interested in your thoughts on that as a medical professional.
I think you've got it spot on. If you think about it, screening is a service performed on individuals in the absence of signs or symptoms. And in the examples that you've mentioned, for example, prostate or colorectal cancer screening, those are predominantly being done on people who don't have, for example, they don't have any belly pain, they don't have any bleeding in their bowel movements or bleeding in their urination or things of that nature. So it's screening. Now, if they had a sign or a symptom, then it would be a diagnostic test. And I think that leads to a slightly different thought process legally as well as from the medical standpoint. Would you agree?
Definitely. And that's the dividing line that I'm suggesting here exists from a reimbursement analysis perspective. And you've got the screening test in one bucket. Then when you move over to diagnostic tests, which are tests that are performed in the presence or to help of a medical professional rule in or rule out a particular disease, then you're dealing with a diagnostic test. Diagnostic tests don't necessarily have to be definitive, but again, they're administered in the face of some clinical evidence that a patient may have a particular disease. And the distinction is important here because, screening tests are, as a general rule, more difficult to get covered by third-party payers and health plans than diagnostic tests because the efficacy of screening tests, their actual link to disease prevention in a population or at a population level, and thus, their overall value can sometimes be difficult to quantify. So payers are a little more reluctant to cover those kind of tests, or they put them in a non-covered category for services that they generally don't do with respect to diagnostic testing. And the screening test, diagnostic test distinctions, obviously, as people listening to this probably fully appreciate, very important with respect to federal payers because Medicare, by and large, doesn't cover wellness and screening-oriented testing with a couple of, very limited exceptions, like the PSA test that I mentioned and Pap smears for women. They generally just aren't in that business. So because so many of the lab tests being marketed to consumers today are screening tests by nature or by virtue of the context in which they're ordered, we see a large segment of the direct access market offering really only cash pay services. They just don't want to fight City Hall on trying to get reimbursed for things that are either screening tests by nature or screening tests because of the context, the healthcare context in which they're actually delivered.
And I think where you're leading to is this increasing interest by many stakeholders in, for example, pan-diagnosis screening tests, pan-cancer screening tests, or screening for immunologic disorders or things of that nature. And it becomes a question from the payer standpoint. Where's the data? Does the data show that your test is better than a coin flip, for example, in identifying people with an underlying condition? But it also raises another question, which is, what are you going to do with that information? If someone, for example, has a screening test done and it shows that that individual might be at risk, I'll say might be at risk for bladder cancer. From a payer standpoint, is there any data showing that screening asymptomatic people, that the benefits outweigh the risks? Payers look at things such as the U.S. Preventive Services Task Force, as well as other entities here in the U.S. as well as outside of the U.S. to see if there's a benefit. And if there isn't a defined benefit, in other words, the benefits outweigh the risks, payers as well as the laboratory benefit managers that payers are increasingly using, payers will say, well, there's not data showing that your test, your screening test is medically necessary. And therefore, it then leads to a cascade of questions. It's not just, is the test necessary, but then if that individual needs further diagnostic workup based on the test, such as an ultrasound or a cystoscopy or just collecting like a urinalysis, does that meet the plan's criteria of being medically necessary? So it's not just the test itself. It's like what happens downstream, and it can have consequences to an individual, especially if a plan comes back 6 months, 12 months down the line and says, you know what, this test that we paid for, we determined all this other workup that you had didn't meet our criteria of medical necessity because this cash pay screening test that you bought in the first place wasn't, and by our definition, medically necessary. So you owe us money. And that happens, unfortunately.
Right. So it's an interesting dilemma. I think that the lab market and people that are interested in using a direct access testing model to sort of circumvent all the work that needs to be done to establish the efficacy of the test, that really isn't something that's probably going to work unless the lab services provider is willing to live with a cash pay model for some period of time while they establish the scientific power of the test to be predictive of a particular condition. So there's really sort of no beating the reimbursement demands associated with establishing, again, the efficacy of the test. Then you've got this sort of double-edged sword. If you start changing the process by which a test is offered, even one that is proven to assist with identifying or de-identifying a disease, in other words, when the science is sort of unquestionably supportive that the test is appropriate, the way in which direct access tests are ultimately ordered can lead to medical necessity denials, as you alluded to, Joel. I mean, if the process that a lab uses to assess whether the patient, clinically speaking, is an appropriate candidate for the test is not robust enough, claims, will be denied for medical necessity, no matter how good the scientific data is for a test. So you can take a test that, there might not be any reimbursement problems associated with administering it through a physician-initiated order, transfer it into the patient-initiated order context, and then you run into medical necessity denials because the screening of the patient, the clinical assessment of the patient, doesn't support the administration of the test, at least in the payer's mind. And what you get when that happens is a medical necessity denial. So this is a tough issue for many labs in the direct access testing market because what they're doing is partnering with telemedicine entities, or in some instances, even creating their own independent physician networks to assess patients for lab tests in what they think is sort of an efficient way. But the problem is if the process becomes too efficient, if it's not thorough enough, it can create reimbursement problems. The goal is to expand the availability of tests, but that laudable goal can create tension with respect to the medical necessity assessment required for diagnostic tests to be reimbursed.
You're coming back to, I'd say, a foundational question. And the foundational question is your test being used for screening or is it being used for diagnostic purposes? Because again, if it's used for screening, insurers, Medicare, they all have language which addresses whether or not a screening test needs to be covered, because taking it one step further, someone who's getting screening would not have financial responsibility by Medicare or by insurance. So even if someone was in a high deductible health plan where they had an out-of-pocket of thousands of dollars before their insurance kicks in, a screening test, if it was medically necessary, would be covered at first dollar. Whereas a diagnostic test, in other words, evaluating a sign or a symptom, becomes different, may get covered by insurance because it's now being ordered, and I'm using that term specifically to tie it back to who orders the test. It's ordered in order to further assess the symptom the patient has. And so usually the assumption would be that the clinician, and you mentioned, for example, telemedicine networks spring up where a physician ordered the test, and if the test was abnormal, then the assumption is going to be that the physician, the ordering physician's then going to initiate some further action, order some other tests, other laboratory tests or imaging tests, or refer the patient for another type of a more invasive assessment test to figure out what's going on. And I think for a lot of labs and a lot of consumers, understanding that difference between screening and diagnostic is very, very important. And it also leads back to the first question I think Megan asked, which is, so who's going to pay for it? Is the patient going to be paying for it out of pocket? Or is there a way that the patient's insurance could be paying for it?
So, Joel, it's a really interesting set of issues. And yeah, this, as you note, this is really all about how labs are going to get paid for direct access testing. And the more pressure that you put on consumers to pay for it, the more difficult it can be. Obviously, everyone would love to have a unquestionably applicable CPT code for a test that's honored in the direct access context. But for all the reasons that we're talking about, that's difficult. And it's why I think the market sort of broadly right now is focused on the delivery of screening-oriented tests on a cash pay basis to patients. One of the things that I think is interesting, and I struggle with this issue in counseling lab clients on direct access testing, is the delivery of the laboratory test results and whether and how that may affect a payer's view of the medical necessity of the test. So let me put a little meat on the bones there. What happens a lot of times is that in the direct access testing world, a patient initiates a test, and with a laboratory, they're essentially, in certain respects, working around their treating physician to obtain more information about their disease that their physician either doesn't know about or hasn't deemed appropriate in one way or another. They initiate the test by going online, communicating with the lab. The lab has the patient sort of clinically screened for test propriety. And then when they deliver the result goes back to the patient and goes back to the physician in the loop that ordered the test for the patient. But that physician is not the patient's treating physician. Let's say they're being treated for cancer and they've got a medical oncologist who's working with them. But this test that they've got is sort of a secondary test that helps them assess the propriety of certain types of therapies for their cancer. But the test is not necessarily being delivered back to their oncologist. It's going back to the physician that screened them for the propriety of the test. And if the result doesn't turn out to be medically actionable because it doesn't land in the right person's EMR inbox, my concern is that creates medical necessity issues. And what do you think about that issue as a physician and as a billing guru?
Ideally, a physician would like to have a 360-degree view of their patient and wants to know, ideally, all of the tests, all of the drugs, all of the treatments that this patient's undergoing. And what you're highlighting is that there's this break, that the direct-to-consumer lab and the direct-to-consumer physician who ordered the test might not necessarily be communicating the results back to the treating physician, whether it's cancer or cancer screening or cardiovascular disease or whatever. So I think the first thing that has to be stated is that regardless of whether it was a direct access or whether it was billed through insurance, you got to get those test results back to the treating clinician or the physician who's overseeing the patient's care for that condition. Now it puts some burden on a number of players within this pathway. Obviously, the patient has to communicate to the doctor, I went and I had this test done and I'd like you to see the results. That puts burden now back on the laboratory company as to where's the literature showing how this test should be used, how the results should be interpreted, what should be done, or at least what should the physician be suggesting that that patient needs next, whether from a further diagnostic or even from a treatment or management standpoint. Because if the lab doesn't have that information that that patient can pull through, then you've actually, speaking with the doctor, you may have actually, whether intentional or not, you may have created a barrier to treatment. Because the patient goes, well, I had this test done. And the doctor goes, well, I don't believe in this test. And the patient goes, well, I did this because you weren't listening to my complaints. And you can see where that goes. And it doesn't go in a positive manner. Whereas if the patient goes, doctor, you really weren't listening to me, I'll go away from cancer. I'll go to women's health, for example. We know that women's symptoms of heart disease are very different than a man's symptoms of heart disease. And so that woman might have gone ahead and gotten the test done and brought it back to her doctor and said, look at these test results. I may be at risk for cardiovascular disease. I really think we should have a discussion and maybe I need some further testing done. You've kind of changed the loop from doctor, you weren't listening to me, to doctor, I'm obviously trying to be an informed consumer and an active participant in my health. And here's the cholesterol results. Do I need a more complete panel with triglycerides and VLDLs and LPAs and things of that nature? And do I need to have further testing in order to determine, do I have a heart risk? And whether I need to be on treatment, whether I need to be on a cholesterol-lowering medicine, or whether I need to be on an exercise regimen, or maybe I've got a silent narrowing in my arteries. I'm trying to suggest that there's an opportunity for all of the stakeholders here to kind of move it from a me versus you to a informed consumer, informed user, using the results of these tests, having the test medical necessity backed up by the literature, and bringing it back to the treating physician or other qualified healthcare professional, nurse practitioner, physician assistant, whoever's managing the patient, say, let's have a discussion.
Yeah, and I think reimbursement becomes much more likely, putting aside the other issues we've been talking about, if the results of a patient-initiated lab test ultimately make their way back to the patient's treating physician. If they get sort of stuck, they go back to the doctor that ordered the test, and that doctor really doesn't have a strong physician-patient relationship with the patient. They've simply been used to, even if they do it thoroughly and appropriately, they've been used simply to screen the patient to determine whether the test that the patient wants is clinically appropriate, and then to order the test. If the results get stuck at that level, in my mind, it just creates medical necessity problems, because the test results are sort of absorbed by the patient. It's a nice to know piece of information, but it's not driving the clinical management of the patient. And to me, it becomes really easy for plans and payers to deny a reimbursement for those kind of claims, because the test just isn't being used in a way that leads to anything positive or valuable for the patient.
That whole question of whether it's valuable to the patient, I think, is really the essence and the crucial question. And the patient may have one lens that they're looking at it. Their doctor may have a second lens.
Right.
And the insurer may have a third lens. So pull back and come back to this, I think, this general question, which is, we have a whole industry that is sprouted around direct-to-consumer testing. And whether it is something simple like cholesterol testing, or do I have an STD, whether something very complex like do I have a hidden cancer, or do I have an immunologic disorder or the like, you always have to think about, if the test is done, what am I going to do with the results of the test? And do I have a firm basis that, armed with the test results, my doctor, my healthcare professional is going to do something with the test, not just dismiss it out of hand?
Thanks, Bob, and thanks, Joel. What a great discussion. Clearly, there's so much to think about. And one thing I want to highlight that we're not going to go into depth with this particular episode, but we touch upon in episode 1. So if you have not listened to episode 1 of this series, please, we encourage you to do so, is we've been talking a lot about reimbursement strategy from the perspective of the payer. But another thing to think about is how the tests you are planning to market and the claims you are making about that test and how it can be used. For example, whether it's diagnostic versus a screening test, and even more in the weeds than that, how that's perceived by a consumer and by the patient, and what claims you're making about that product. And that becomes really important from a variety of perspectives outside of reimbursement as well. Both FDA and FTC come into play there. So this was just, I can't emphasize enough, this was a great discussion today, and we've gone over a lot of information. And these decisions around coverage and reimbursement of a product from a strategic standpoint are clearly not always straightforward. There's a lot to think about. How can labs and other stakeholders in the direct access market get in front of these challenges? If you were to give them a sentence or two of advice, which I know is difficult given all of the considerations here, how would you advise labs and stakeholders on that front?
Gosh, Megan, if a lab is starting to think about these issues, the time to start thinking about it was yesterday. Reimbursement's a game, and obviously you don't want to be the ball.
I think what I would add is similar to what Joel is saying. You got to start early and assess the type of testing that you want to offer before you go into the direct-to-consumer lab testing business. You want to know whether you're offering a screening test, reimbursement, or a diagnostic test, and how that's going to impact reimbursement. The other thing that's critical, and I don't want to completely neglect compliance issues since we noted that it would be discussed at some level, is if a lab is going to use a physician in the loop model, in other words, it's going to have a relationship with a physician or group of physicians that will be responsible for evaluating patients and ultimately ordering the test from the laboratory for the patient, you're going to have to be extremely cognizant that the relationship between the laboratory and the physician does not violate state fee splitting laws, or worse, the federal anti-kickback statute, or a state kickback statute that might apply to commercial payers. Now, again, obviously, all of that is implicated most of the time only when you have a third-party payer paying for the test. And it's yet another reason why I think the industry right now is gravitating toward a cash pay model. It just cuts out a lot of the compliance concerns that you would have.
Yeah, but I'll just add one last thing to that. I'm not the lawyer, but you still have compliance and regulatory issues about the claims that you're making about your tests. I mean, we've seen over the past decades, the FTC and the FDA weighing in on these direct-to-consumer laboratory business models. So I think you have to be very, very clear on the claims you're making with your marketing. And I think you have to have a process with that person, to that consumer, that makes it very clear what their financial responsibility will be if they're going to bill it to insurance and insurance denies payment and coverage for your test. Because in this era of social media, the last thing you want is online forums with negative comments about your test.
Yeah, absolutely. The communication with the consumer is critical, and it is unquestionably an enforcement and in certain respects a reimbursement issue in and of itself. And the worst thing that can happen is, you start making claims about the power or efficacy of a lab developed test, and in making those questionable representations, you attract the attention of the FDA, and the FDA decides that it's going to stop exercising its enforcement discretion over LDTs, which happens from time to time on a case-by-case basis. and you end up with an LDT that gets regulated, at least in terms of the statements that are made about it from a labeling perspective by the FDA.
Great. Well, thanks again to both of you, Bob and Joel, for your insights today. That is all the time we have. Thank you so much to our listeners. I'm your host, Megan Robertson. If you like what you've heard today, please don't forget to subscribe. Diagnosing Health Care is available wherever you get your podcasts.
Thank you for listening to Diagnosing Health Care. For show notes on today's episode, additional episodes, and more insights on trending issues in healthcare, please visit diagnosinghealthcare.com and be sure to subscribe on your preferred platform. The Employment Law This Week and Diagnosing Healthcare podcasts are presented by Epstein Becker Green, PC. All rights are reserved. This audio recording includes information about legal issues and legal developments. Such materials are for informational purposes only and may not reflect the most current legal developments. These informational materials are not intended and should not be taken as legal advice on any particular set of facts or circumstances, and these materials are not a substitute for the advice of competent counsel. The content reflects the personal views and opinions of the participants. No attorney-client relationship has been created by this audio recording. This audio recording may be considered attorney advertising in some jurisdictions under the applicable law and ethical rules. The determination of the need for legal services and the choice of a lawyer are extremely important decisions and should not be based solely upon advertisements or self-proclaimed expertise. No representation is made that the quality of the legal services to be performed is greater than the quality of legal services performed by other lawyers.